All right, good morning, everyone. It's my pleasure to introduce Dr. Robert Bowers. He's a sports medicine physiatrist at Emory University in Atlanta, Georgia. Prior to medicine, he played Division I baseball at Furman University and received a PhD in exercise physiology from Auburn University. He attended medical school at PCOM, Georgia, and completed a residency in PM&R and sports medicine fellowship at Emory University. His current clinical and research interests include baseball medicine and throwing athletes, interventional ultrasound-guided procedures, and diagnostic ultrasound. Specifically, Dr. Bowers is interested in neurogenic thoracic outlet syndrome and peripheral nerve conditions in throwing athletes. He's the director of the Emory Baseball Medicine Program and serves as a team physician for Georgia Tech Baseball, the Atlanta Braves, and the College Park Skyhawks. Dr. Bowers will be talking about Pronator syndrome today. All right.
Okay. Thanks, Brennan. I appreciate it. Let's go to the beginning of this and get into presentation mode. All right. I assume everyone can see this.
Yes, we can.
All right. Okay, perfect. Okay, well, thanks to Brennan and to Ryan Cruz and for everyone involved for inviting me to give one of these talks as part of the ultrasound case series. So we'll talk about Pronator syndrome today. I don't have any financial disclosures. I do want to give a shout out to these other docs on here that are friends of mine and graphers in their own right that have contributed at least a couple images to this talk. So thanks to them for helping me out with this. So we'll get right into our case. So we have a 26-year-old professional baseball pitcher with insidious onset, intermittent, vague, volar, anterior proximal forearm pain that's associated with arm fatigue and loss of velocity when he's pitching. This will radiate distally and it'll radiate proximally into the antecubital fossa. He has intermittent paresthesias in the hand. He's not really sure, but thinks it's worse than the thumb and the index finger. His symptoms are worse with pitching and associates it to more of the late cocking and early acceleration phases of pitching. He has tenderness to palpation over the flexor pronator mass. He has pain with resisted forearm supination and pronation, with pain with resisted elbow flexion and with gripping. He does not have any weakness at the elbow, wrist, or hand appreciated. Now, I wish this was actually the real case we're going to talk about. This is actually a CAQ question that I wrote for a CAQ review session last year. So this is what you would see in a high-level professional athlete, but our real case is this one right here, which is that the images that we're going to see today are coming from this patient. So we have a 65-year-old male hardware store worker who presents with insidious onset, vague right proximal forearm pain with radiation into the antecubital fossa and distally into the mid forearm. All right. It's intermittent, worsened with activity such as lifting or gripping. It ranges in severity from 2 out of 10 at rest to 8 out of 10 with activity. He does complain sometimes of severe pain that impacts his ability to work. This patient does not have any numbness or tingling. It's more of that isolated pain. He has tenderness over the volar forearm, kind of moving medially towards the flexor pronator mass, and he has pain with resisted wrist flexion, resisted elbow flexion, pronation of the forearm, supination of the forearm, and with gripping. He was originally seen by another doc. He was diagnosed with distal biceps tendinopathy. The differential that time also included possible bicipital radial burstopathy and flexor pronator mass strain. There was no mention of Pronator syndrome at that time. The patient completed a course of oral anti-inflammatories and physical therapy without improvement, and he had an MRI ordered to evaluate the distal biceps tendon. So the imaging showed elbow X-ray was normal. Right elbow MRI was not very impressive. He had some mild tendinosis, common extensor tendon, mild, if any, elbow joint osteoarthritis. The distal biceps tendon was totally normal. No evidence of bicipital radial burstopathy, and all of the musculature was normal as well. So he was referred to me for diagnostic ultrasound to see if we could see some things dynamically and try to figure out what the pain generator was. So we'll go into talking about the anterior elbow scan. I'm sure everyone is familiar with the curriculum guidelines for sports medicine fellowships, but the updated paper from last year, this is it, go into it. So we're going to follow that as far as the structures of interest for our anterior elbow scan. I'll also go into medial elbow scan a bit too. We won't do a complete, but there are some structures that we'll go over. So these are the structures for the anterior elbow protocol. The last three that are in italics, those are ones that you can look at. It's not part of the formal scan, but if it's associated with the presenting symptoms for the patient, then you certainly can look at them. And one thing to keep in mind is with this protocol, and probably with a lot of ultrasound protocols in different areas, is there's significant overlap of structures. So on certain views, you can see multiple of these structures. And so just keep in mind that you can see different things at the same time as part of your scan. For the medial elbow protocol, what I'll go over real quick is just common flexor pronator, common flexor tendon, flexor pronator mass, ulnar collateral ligament. I wouldn't be a baseball medicine doc or instrument throwing athletes if I didn't talk about the ulnar collateral ligament. So it's kind of a foregone conclusion. And so we'll also talk about the ulnar nerve as well. So let's get started going through the protocol. So here is our home base of the anterior elbow. So these are going to be good scans on a really great Samsung machine. There are a couple different machines throughout, so some picks are better than others. So this is our home base anterior elbow. You see where the probe is in short axis, and we can see multiple structures here. It's a good place to kind of get your bearings and start. So we're going to see our brachialis right here in the middle. You'll see your biceps tendon on top. And if you scan a little bit proximally distally, if you come proximally a bit, you'll see the biceps muscle coming in. Medially, we'll have our median nerve right under the brachial artery. And then laterally, you'll see that brachioradialis and the radial nerve come in. And so it's a good place to get your bearings. We have our trochlea here and then capitellum coming towards the radial side, sorry. So first thing we'll look at is going to be our joint recess. And so where we are at home base, you can scan a little bit distal to kind of get a picture of the joint recess in short axis. And then we also can come here, see your joint recess over the capitellum on that side with to see if there's any sort of effusion or sail sign or anything like that. So we'll check our joint recesses first. I also like to check the joint recess. If we're going to do it and put it in here, check the joint recess posteriorly. I feel like that's a good place where I typically will see a fusion more so than I can see it anteriorly. But sometimes I'll go in and I'll check posteriorly with the joint recess here, but I didn't add any pictures for this talk. So then we'll go into some of the musculature. So we'll start with the biceps muscle and the brachialis muscle. At the same time, we can look at the musculocutaneous nerve because it's going to be there. And so might as well look at it as we're scanning for the musculature for the biceps and the brachialis. So if we start at our home base, come a little bit proximal almost into the mid upper arm, we'll see biceps on top, brachialis underneath, and sitting right in between them in the fascial plane will be your musculocutaneous nerve. So I'll get a sense of the musculocutaneous nerve, even though it's not something I'm worried too much about in this particular case, but we look at it just because. So we'll come over the musculocutaneous nerve and we'll flip into long axis, and just to take a look at the muscle and long axis as well, we see the nerve kind of running through between the biceps and the brachialis. So we'll start there. Then we can kind of focus on the brachialis a bit more. So we have our brachialis muscle here, and we're looking at it in short axis and can scan proximal distal just to get a sense of the muscle. Is there any abnormality there? And we can flip into long axis and come more over to the ulnar side, and we can look at the brachialis insertion as it comes down onto the ulna. And then, as I mentioned previously, in a lot of these scans, you can see multiple things at the same time. And we can also get a sense with our pronator teres musculature on top as well. Then we'll move into our biceps tendon. And so biceps tendon in this view, kind of at the anterior elbow, before we get into some other views, sometimes it's difficult to go all the way down to the insertion. So we'll look at the biceps tendon here, but there's some other views where we really want to get a good look at it from a diagnostic standpoint. At any rate, so we're looking at the biceps tendon in short axis here. So we'll start at our home base view where we see that biceps tendon on top, and then we'll just scan distally and follow the tendon in short axis down. And as you follow it down further and further, you're really going to dig your probe into the forearm to be able to get a good view the tendon. And this image right here is actually a really good short axis image of the tendon very distally. So we'll follow it down kind of as far as you feel like you can get a good image of it. Then we'll flip into long axis, and same thing, the tendon will kind of dive down deep as you're coming distally. And this again is a good image where you can almost get a good view of that tendon kind of inserting distally down onto the radius. Kind of the more the money shot for the biceps tendon from a diagnostic standpoint is going to be in your pronator window. So this is definitely a challenging scan, and I think that it's one that kind of trips up our fellows. But once you get the hang of it, it's a really it's very satisfying when you get that good picture of the artery and the tendon underneath, and you can see it dynamically moving. And so what you do is you start at the medial epicondyle, and then you're just going to scan distally over the forearm. And so we have our probe over the medial epicondyle here, and then we'll start coming down distally with the probe in this orientation. So kind of a little bit diagonal with the bottom side of the probe as kind of the leading edge, we'll call it. So you scan down until the thing you want to look for is this brachial artery. And so you'll see the artery pumping. And so once you see the artery as you're scanning distally, stop there and then clean it up, and you'll see that biceps tendon coming in nicely right underneath the artery, and we see it inserting down here on the radius. And then you can supinate and pronate, and you'll see that biceps tendon moving. And so this is the best view diagnostically to look at the distal biceps tendon. It'll allow you to see if there's significant tendinopathy or tears or anything like that. Here's just another view of the pronator window. We see that artery sitting right on top with the tendon right underneath coming to insert. There's a little bit of tendon thickening here, showing a little bit of tendinopathy as it inserts into the radius there. So our next view of the biceps tendon is going to be our Cobra view. So Cobra view is helpful from a procedural standpoint. So the pronator window is great for diagnostics, but you're certainly not going to do a procedure there because of the artery in the way. And so we flip into Cobra view, where you can't see nearly as much of the tendon, but you can see that insertion, and you can also access it for procedures. And so we see this Cobra view right here with the arm placed in this position and in that Cobra position. And you can see the distal insertion, and you can do some diagnostics here. We see in this distal insertion, there's a small tear in the tendon kind of longitudinally. And so we can do some diagnostics here. And then also this is going to be the place, and it's what I use if I'm doing a distal biceps procedure. I use this view to do the procedure, and we see that needle coming in here right into the biceps tendon there. You can also look here for any bicipital radial bursopathy. So if you look at this image down here, you see that bicipital radial bursa kind of wraps around the distal biceps tendon as it inserts here. And so you can do some dynamic scanning in the Cobra view where you can supinate and pronate, and you can see if there's any bunching or evidence of any fluid around that distal biceps tendon. So can do some diagnostics in this Cobra view as well, but also very helpful from a procedural standpoint. So now we'll move into the median nerve, and we see the median nerve here. And so you are going to go back to your home base, and you'll come over medially over that median nerve where it sits next to the brachial artery. So you're going to start there, and then we're going to scan distally and follow the nerve. And so this is close to our home base right here, where you'll see pronator teres coming in on top. You'll have brachialis on the bottom, our median nerve here. And then we're going to begin to scan distally. As you scan distally, that median nerve will start to dive a little bit deeper. And then you'll see the ulnar artery kind of come across and cross underneath the median nerve. And so keep an eye on that, because right after you hit the ulnar artery and you keep coming distal, that's when you're going to get your ulnar head of the pronator teres. So when we look at the pronator teres here, this is a humeral head, and most of the pronator teres is a humeral head, and the ulnar head is somewhat subtle, and you catch it right after or almost right as the ulnar artery is coming in here. And also we can see in these views that we can assess the volar forearm musculature as well with pronator teres and brachialis here. And as you come more distal, you start to get some FCR, and you can also see FDS, and FDP will come in a bit later too, all the way over to FCU. So just keep in mind, as we're scanning some of these nerves and tracking them and following them, we can also keep an eye on some of the musculature as well and see if we see any abnormalities. So here's some probably better nerve pictures from the Samsung machine. And if we flip on, and we have our probe here, and we flip into long axis, we see pronator teres, humeral head, brachialis underneath, with the nerve kind of coursing between the two of them. And over the picture on the right side, and so this is just after that nerve is kind of, we see the ulnar artery coming up underneath the nerve, and this is just as we're coming distal to it. And you'll see that pronator teres ulnar head kind of start to slip in right underneath. And so you have your humeral head on top, and that ulnar head will be subtle and it'll come in. And so this is where you have kind of your true pronator syndrome or pronator compression, as that nerve sits between the humeral head and the ulnar head of the pronator teres. This is just another picture of the nerve in long axis, a little bit more proximal with the pronator teres on top, brachialis on the bottom. And we see how the nerve is coursing nicely between the two muscles there. So important, while it is difficult and a little bit more challenging to look at nerves in long axis, it's important because you can get some good information of the nerve in long axis, where in short axis, we certainly can do cross-sectional area measurements, but in long axis, you get a better view of kind of the whole, the length of the nerve, and you can see notching or any focal compression in certain areas. So it's a very helpful view to look at the nerve in long axis. So we're coming back to the pronator teres, humeral head, and ulnar head, and we'll see on the video here, just as we're dynamically supinating and pronating, you can see how the nerve kind of could easily get pinched between the humeral head and the ulnar head in certain situations if you're doing a lot of those movements over and over again. So we'll see that here, supinating and pronating, and we'll see the nerve kind of coursing between the two muscles. We'll play that again. And we see that here. And again, can look at FCR musculature and the pronator musculature at the same time. So with median nerve, we also want to keep our eye on the anterior interosseous nerve. So in the same vein, where we'll talk about once that ulnar artery passes under the median nerve, we look for the pronator teres ulnar head. You can also, right after that, look for the branching of the anterior interosseous nerve. It can come off in a little different location. So it can come a little medially, it can come a little bit underneath the main branch of the median nerve. So just keep an eye on that. A little hard to do diagnostics with AIN, but it's good to keep your eye on it just to see when it branches off. And just a quick note on, if we're talking about pronator syndrome versus anterior interosseous nerve syndrome, or some of these syndromes that are a little more proximal to the carpal tunnel, median nerve compression more proximally, anterior interosseous nerve syndrome is going to give you purely motor findings. So patient's going to come in, they're going to have no pain, they're going to have no sensory deficits, they're just going to have difficulty with like buttoning the buttons on their shirt, and they'll have some motor deficits with some of the more fine functions of the hand. And so you can try to delineate there between that and a pronator syndrome, which is going to give you more pain. It may have some numbness and tingling, may have some motor findings, but it's going to be more pain related, where AIN is purely motor. So just keep that in mind. And as you're scanning the median nerve, just keep an eye out for that AIN branching off as you're coming distally. As I mentioned before, we'll look at the volar forearm musculature. For the purpose of this talk, I've kind of kept it more on the medial side or the ulnar side. We don't go over, I don't have some pictures more radially. We're specifically looking at the muscles, where we look at brachioradialis and the supinator and the ECRL and ECRB. We can certainly look at those too. For the purpose of this talk, we're kind of more medial, and certainly you can see all the musculature here. And we keep an eye on that as we're scanning the median nerve down, where we see the pronator teres, FCR, you'll see FDS and FDP coming in. Even as you come more distal and then you're in the mid-forearm, we can see FPL, palmaris longus sits at the top, FCU as you're looking really far medial. So you can get a good sense of if you see abnormalities in any of these specific muscle groups. So just keep an eye on the muscles, and it's very, very important to know your anatomy for this section too, because you think back to med school and the forearm musculature, and even for us in PM&R, when we're talking about doing EMGs and needle testing, the forearm musculature is certainly difficult to remember. And so I think just knowing your anatomy really well when we're talking about these volar forearm scans and anterior elbow scans is something important to keep in mind. So now after we scan the median nerve, we come back to our home base and we can come over and we'll scan the radial nerve. And so we'll come over more to that radial side. We'll see some of the radial musculature here as well. So we're medial here, median nerve brachial artery, biceps tendon brachialis, and then come over and we'll see that brachioradialis coming in on top of the radial nerve over here. So we'll start at the radial nerve at that home base and we'll start to scan distally. As we do scan distally, pretty soon after you leave home base, you'll see that branching of the posterior interosseous nerve and the superficial radial nerve. For the purpose of this talk, we'll follow the posterior interosseous nerve. That superficial radial nerve is going to come superficial, and that becomes more something we're more interested in as we get down towards the wrist. So from an elbow standpoint, we'll focus on the posterior interosseous nerve here. Now we're coming down a little bit more distal. We're following the posterior interosseous nerve. And as it gets down to the arcade of Frosch and the supinator, where you can get some radial tunnel syndrome. So we followed it down distally. We're right over the top of the radius. We see brachioradialis here, ECRL here, and the supinator kind of coming in underneath. And we'll see the posterior interosseous nerve coursing through the supinator here. So the way that I easily find this, you certainly can start up at the elbow and scan distally to get to this point, but you can also just put your probe right over the top of the radius, kind of at the mid forearm, and scan proximal to distal, and you'll see that posterior interosseous nerve fairly clearly kind of pop over the top of the radius. And so that's a good place to find the posterior interosseous nerve at the supinator to look and see if you can notice any flattening or compression of the nerve, possibly even some focal cross-sectional area increase to get a sense of if there's some compression. And then this is where you would do an injection, or where I do all of my posterior interosseous nerve injections and hydrodissections is at this level, certainly, as you can see in the picture right here. So this is just an image of the nerve coursing through the supinator. We'll see it coming here, kind of popping across over the top of the radius. And so again, here, as you follow it and you're scanning dynamically, you'll see the nerve pop right over the top of the radius, kind of coursing through the supinator. So that's a good, easy place to find the PIN. Or if we're doing it more of a stepwise approach, you start at your home base and you scan distally. You'll see superficial come off, and you can scan the posterior interosseous nerve as it comes distally and courses down through the supinator. So here's just that stepwise approach. So we start our probe at the elbow, we scan distally. We start here at the elbow, radial nerve, we start to scan distally in the short axis, keep that radial nerve in the center of the screen. You'll see that bifurcation, and then we come over to the posterior interosseous nerve and we follow that down kind of at level 3 here, where we see the nerve coursing through the supinator, popping over the top of the radius. So just a stepwise approach as far as following the radial nerve. So now real quick, just check the time here. So real quick here, we'll go through the medial elbow, just a couple structures of interest that I would do in this case. I wasn't thinking really strongly medial elbow, so medial epicondylitis, or he's certainly not a throwing athlete, so I wouldn't think UCL, but we will take a look at that flexor pronator mass. So we'll do some scan of the medial elbow for this patient in particular. So this is not a complete scan. So that common flexor tendon origin, which I think all of us are aware of, is a shorter, broader tendon. So if you look on the lateral aspect, the lateral epicondyle, it's a longer tendon, where at the medial side, it's very short and broad. And so we see the tendon insertion kind of right here on the medial epicondyle with your probe in this position. Now we see here in the long axis and short axis, so viewing that tendon in long axis here and then flipping and taking a look at the tendon at the insertion and the short axis as well is important. We see some pathology here with tendinosis and long axis. You see some of that tendon thickening and just that bulky kind of hypoechoic tendon with some neovascularity on Doppler. Just a little video here, and you can see some of that neovascularity indicating tendinosis. And here's the same thing without the Doppler on in short axis, and you just see that kind of bulky, unhealthy looking tendon in short axis as it inserts there. You can also look at the muscle as well, flexor pronator muscle. We see a partial tear in this situation. As we scan distally, we see that tear in there. So we can see the tendon insertion with some tendinosis, but we also see that partial tear of the muscle here as well. So now you go to the UCL from the common flexor tendon. I think this is just a pearl to remember, not necessarily significantly helpful for this particular case, but just that windshield wiper approach to get from the common flexor tendon to the UCL. And so you start at the medial epicondyle looking at the common flexor tendon, which is a little bit easier to identify. You anchor your probe at the medial epicondyle and kind of scan down. You fan down and you'll see that UCL coming in. So look at the common flexor, anchor the heel of your probe on that medial epicondyle, and then fan down and you'll see the UCL coming in. So we see here we're starting on the epicondyle, fanning down, and you'll see that UCL coming in here and see that insertion on the sublime tubercle nicely. So again, fan down from the medial epicondyle to get that UCL to come in. And so just one point on anatomy with the UCL, the one that we're interested in from an injury standpoint and throwing athletes, we're talking about with Tommy John surgery and UCL reconstruction is the anterior band. So just realize that we're looking, in the previous images I showed, we're looking at the anterior band. So again, your orientation, some of the anatomy with the UCL coming across and inserting on that sublime tubercle. We see that there. Here's just the dynamic scan for the UCL. We see here we're putting some valgus stress on that elbow, and we can see how that plays out on the ultrasound scan. We see again the UCL coming over nicely, inserting on sublime tubercle, no evidence of any pathology, and no increased gapping compared, and we'll compare side to side. Lastly, medial elbow is going to be your ulnar nerve, which we're going to look at here at the medial epicondyle. That's where I like to identify the ulnar nerve. If I have some issues at the medial epicondyle, I'll come into the mid forearm and kind of find it between the musculature there and follow it up. But should be fairly easy to find it at the medial epicondyle. So we see the nerve here with our triceps sitting right next to it. And so we see the ulnar nerve, and this is just what we can do as far as measuring cross-sectional area of the ulnar nerve, which can give us certainly some information of whether there's a cubital tunnel component or ulnar neuropathy at the elbow. We scan down a little more distally, we'll find the nerve between the two heads of the FCU as we kind of get into more cubital tunnel proper, as we come a bit more distal. Also important to look at the ulnar nerve and long axis, like I mentioned with the median nerve. And so in long axis, you can see kind of focal notching or compression that maybe you may not be able to appreciate in the short axis view. It's challenging to look at the ulnar nerve, and in long axis, just some of the bony prominences that are in the area that make it a little bit difficult. But once you get the hang of it, it's certainly a helpful view to look at for pathology. And we see that there. And lastly, for the ulnar nerve, our dynamic scan, when we bring the elbow into flexion, we're looking at the medial epicondyle, and we'll see the nerve dislocate here. And actually here, we actually some snapping triceps as well. And we see the triceps come across as well. So we see that again here. Good. And the other image, the depth is way off on this image. Sorry about that. But we see the nerve kind of partially subluxing here on dynamic scan with elbow flexion. Now we'll get back into our case after going through the anterior elbow scan and part of the medial elbow scan. So our original differential included distal biceps tendinopathy, as well as flexor pronator mass, bicipital radiobursopathy. The MRI in the area of interest and of the elbow did not show any evidence of real pathology in the area of interest. And so they were referred to me for diagnostic ultrasound. And I do a lot of diagnostic ultrasound guided injections to try to locate pain generators when we don't see a ton on imaging. And so I think there's great utility from an ultrasound standpoint doing diagnostic ultrasound guided injections to locate pain generators. So that's just a pearl for me. I think there's huge utility there to help us with the diagnosis. So we're coming back, we're going to focus on the pronator syndrome and the median nerve now, and just come back to look at those previous images that I had showed and images that we'll look for in this patient. These are just nicer images because we're on the Samsung. I saw this patient at one of our satellite clinics, and so we had an export there. We didn't have one of our nicer Samsungs or Canon machines, which give us a little bit clearer picture. So the pictures I'm about to show are on the Sonosite, which just aren't quite as clear. So we're looking here, you'll see the center line on some of these images. I just like to use that as I'm scanning over the nerve to kind of get right over it. So when I flip into long axis, I know I'm in the same location. So I apologize if that kind of throws you off a little bit, but I use the center line fairly frequently when I'm flipping in the long axis on nerves. So we see the nerve here, and this is more where it has normal cross-sectional area, and this is just distal to the true pronator between the humeral head and the ulnar head. And as we scan up proximally, you'll see you get this kind of focal enlargement of the nerve, which is giving you evidence that there's compression of the nerve, and then it backs up like a water hose, and so that nerve will swell just proximal or distal to the area of the compression. Here we see it proximally, and so you see nerve, if you go back and measure it, it was 5 millimeters squared here, and we go back and measure it's 12 millimeters squared here, and certainly that's abnormal for those of us that do nerve scannings. We're looking at it in long axis here. This is a little more distal where you see the nerve normally in long axis. And then as we look here, and we have a couple other long axis views, it certainly isn't the best. We see the nerve coming down this way, and you see this focal, and this is the area where it was enlarged in cross-sectional area and short axis. To kind of see this focal swelling of the nerve where it comes back kind of a normal caliber here, and you just get this focal swelling in the nerve as it comes through right here in long axis. We see these long axis images, same as well, kind of more normal as the nerve gets through here, and you see this hyperechogenicity and kind of indicates some focal inflammation, and then swelling of the nerve you get these helpful images on long axis view. And we see similar on the picture on the right-hand side. So if we come in here, here is a video in short axis, and I'm just scanning dynamically in that area where you had that focal enlargement of cross-sectional area. And so we do dynamic, and then as we come distal, you start to see that nerve kind of flatten out a little bit. Gives you some indication that there's some compression of the nerve going on there, and then more proximally, you get that focal swelling of the nerve. And so we'll look at that again. We're scanning dynamically, just looking to see if there's any dynamic compression that I can appreciate, which I don't really in this situation. And then we stop the dynamic scan and come a little bit more distal, and you'll see that nerve just get pancaked a little bit. And it's an indication of some compression through there. And then we have that focal swelling on the backside. Another video here as well, and this is just us scanning it. So you started there, we're scanning up and down. So again, where we start, we're going to be distal, and you'll see kind of a normal nerve caliber. It's about 5 millimeters square. And as we come proximal, you'll see it pancake down a little bit. And then as we come up a little bit more proximal, you'll see that nerve swell and get enlarged. So normal nerve caliber here, we're coming proximal, you see it get kind of squeezed through there. And as we come up, it swells a bit. Normal, squeeze and kind of compress down there, and then enlarges there. So these are just some images that I got from Brett Kendall, who had a couple pronator syndrome patients. Got just a couple more minutes, so hopefully we'll be done right at around 30 minutes. And so we look at this video here, and we'll see this nerve just kind of get kinked right through here as we're scanning distally. So again, to get your bearings, we're going to be looking at this median nerve right through here. As we're scanning down that median nerve, you see it kind of get kinked as it wraps around right there. And here we're looking at it in short axis, and maybe in short axis view, you don't appreciate kind of the notching of the nerve as much as you're going to see in long axis. So this is a short axis view here. We flip into long axis, and you see this nerve kind of get kinked through there, and you can really clearly see that focal compression of the nerve indicating pronator syndrome there. So I think that's a great image in long axis to clearly see the kinking and compression of the nerve. We'll look here, we're scanning dynamically. And that one I like because it shows that focal compression. So as you scan dynamically, you'll see the nerve look fairly normal, and then it kind of flattens out again through here. You'll see that normal scan distally squeeze, flattened out through there, and then it kind of comes back to more of a normal look after that. Then here is a video of an injection. For some reason, I went back to get my videos from my patient, and for some reason I didn't have. It's probably because I was by myself and I couldn't grow a third arm to take a picture. So I did not have a picture of the injection that we did for my patient. And so here's just an image of an injection around the ulnar nerve, or kind of hydrodissect it. We see the needle coming in here with the nerve here, and see that halo of fluid kind of filling up around the nerve. Again there. So with these nerve injections, we play chicken with the nerve a little bit and just get that needle as close as we can to the nerve without poking it, and try to get that halo of fluid around it. Here we go. Again, needle coming in, nerve is right here, needle coming in here. We're going to start underneath, and this is what I'll try to do with a lot of my nerve injections. We'll kind of try to get fluid underneath the nerve, and then we'll pull back, and we'll get that needle on top of the nerve and put some of the injectate on top, just to kind of really cover it and get a nice halo of fluid around the nerve, which we see from the needle here. Here as well, injection around the nerve. And these are the views that you're going to see for a pronator syndrome type of injection. You're going to come to that area of either focal enlargement or where you see compression, and just inject around the nerve. For my patient, it was more, we isolated where his focal pain was and then did the injection there. So from a diagnosis and treatment standpoint, diagnostic ultrasound and the patient's presentation was consistent with pronator syndrome. So after I saw the ultrasound images and we kind of focused in on pronator syndrome, I ordered an EMG, and there was conduction velocity slowing of the median nerve across the forearm. And so that also is consistent with pronator syndrome. And so we had our ultrasound findings, we had EMG findings, and then lastly, I did an ultrasound guided diagnostic median nerve hydrodissection with lidocaine, dexamethasone, and saline. And with that diagnostic injection, the patient had complete relief of his symptoms for 2 to 3 weeks. And I did the injection. We kind of isolated his area of maximum pain, injected and did a hydrodissection of the nerve right in that area, and complete relief for 2 to 3 weeks. Now, because he didn't get long-term relief, we had a discussion of what do we want to do next. And so I offered, you can have a surgical consultation to see if they would want to talk with you about decompression of the nerve, or we could do a series of ultrasound guided hydrodissections. And generally, if I'm going to do that series, I use a dextrose prolotherapy. And so he decided to try the injection series first. So we did a series of 3 ultrasound guided median nerve dextrose prolotherapy hydrodissections. We did this once weekly for 3 weeks, and this was back in August. And so I followed up with him just by phone last week, just to get a sense of where he was. And 3 months after the series, he continued to have complete relief of his symptoms. And so if his symptoms come back, I think we'll decide, do we do another 3 series versus do we send you for surgical consultation? Now, if we did send for surgical consultation, another thing that ultrasound can help with is identifying the focal area of compression to help the surgeon know, hey, this is where we need to do the decompression. So in the pre-op area, you can come in, scan them, label right where that impingement is and where that focal compression is. And then that way the surgeon knows when he goes in, maybe his incision doesn't have to be as long because he knows exactly where the impingement is, where he can do his decompression, his or her decompression. So from a report standpoint, really briefly, these are what my reports look like, just kind of have some general information on top. And then from a finding standpoint, if it's normal, I just leave it and say it's normal. I don't put a lot of extra words in. And so if the area is normal, I say normal. And then really the abnormality for this individual scan was there's increased median nerve cross-sectional area at the level of the pronator teres, with that cross-sectional area being 12 millimeters squared. We also see notching and compression of the nerve just distal to the area of increased cross-sectional area. And we had a cross-sectional area of the nerve there of 5 millimeters squared. So certainly in a short area, we have a significant increase in nerve cross-sectional area, indicating that compression of the nerve. Everything else was normal. And then my summary was findings consistent with right pronator teres syndrome as detailed above. With that said, I went a couple minutes over where I wanted to, but at any rate, thank you. And I'm happy to take any questions.
Robbie, that was fantastic. Those are some really, really great images, high quality images in the anterior elbow. So thank you for putting all that together. I think, a couple of things I just want to point out. I know we got started a little bit late this morning, but a couple of things that you highlighted that are really important. One is the home base of that kind of anterior elbow cartilage and the brachialis is just a really, it's a really key place for anyone who's doing anterior elbow ultrasound, especially if you get lost. You can always kind of get back to that home base and you get that really characteristic view of the large brachialis muscle on top of the cartilage. And it makes it easy to kind of find your way again if you kind of don't know where you are. And so that's certainly one key. You also pointed out that the anterior elbow scan isn't always just limited to the anterior elbow scan. Making sure that you're going back and forth and finding clinically relevant things either in the medial or lateral elbow is always important. So including that flexor pronator mass and someone who maybe had that clinical history is very important, even though that's maybe not necessarily technically part of that anterior elbow scan. Other things you pointed out that I think are really key, the distal biceps is a really difficult thing to scan. And so you really highlighted the heel toeing in at that distal portion when you're looking anterior, but also when you had your axial view of the anterior elbow, you notice that the brachial artery sits just medial to the distal biceps tendon. And that really highlights when you look through that pronator window, why the brachial artery sits quote unquote superficial to the tendon. It's a really good landmark to find that distal tendon. Other things, that you highlighted, especially, your nerve imaging was great. In the elbow, long axis views of these nerves can be really challenging because they tend to dive back and forth between muscles, and so they don't just follow a direct course. If you're in the forearm or if you're over the humerus, they do, but through the elbow, they don't. And so, really, I think that centerline feature that you mentioned to help you rotate is a good key for, especially for our fellows as they're kind of learning nerve ultrasound, to really help them rotate on that structure. And you pointed out exactly the key for imaging for pronator syndrome is that dynamic scanning, looking for that dynamic compression and sonographically localizing. I think Jeremiah Ray at last AMSSM had said kind of his sonotunnels, I believe is what he said, and kind of using that sonographically localized tenderness, palpation, and reproduction of symptoms is key. So any questions from anyone else tuned in here? All right, well, we will go ahead and end for today then. Thank you once again, Dr. Bowers, and we'll be back again in a few weeks.